Good morning, everyone. I'm Dr. Nisha Parveen Chittu Babu, and I shall be teaching the venous drainage of lower limb for today. Learning objectives for this session are by the end of this session, you all should be able to enumerate the veins of the lower limb, describe the anatomical course and the drainage pattern of saphenous veins, understand the significance of soleus in the venous drainage of lower limb, and know why the soleus is being called as the peripheral heart. Understand the significance of Treadle and Buxton in assessing the venous insufficiency. And finally, explain the anatomical basis for varicose veins and deep vein thrombosis. Overview. So these are the headings under which I shall be teaching the topic. I shall start with introduction, move on to the classification of veins draining the lower limb. Description of each set of veins is next. Then I will talk about the factors which are helping the venous drainage of lower limb. Then move on to the clinical aspects and then summary. And finally, I shall end it with a very quick summary of 5 MCQs, that is multiple choice questions. Before venturing into the topic, let us have a quick look at these pictures I have put up here. The first one is varicose vein. The second one belongs to deep vein thrombosis. Let us talk about the first one first, varicose vein. You might have seen this, right? Especially in adult population, in your parent, neighbor, somewhere you might have seen it, right? Because it is very much prevalent, amounting to almost 23% of adult population of America have got this varicose veins. The second picture, deep vein thrombosis. Deep vein thrombosis is, just by the looks of it, it is looking quite dreadful and dangerous, right? Yes, as dangerous as it looks, it is can lead to pulmonary embolism, leading to sudden death. A common factor between varicose veins and deep vein thrombosis is venous insufficiency. That is, something has gone wrong with the venous drainage of lower limb. Why am I telling you this? Because so that you understand the gravity of learning about the venous drainage of lower limb. Now, let us venture into the actual topic. So, let us start with introduction. What is this venous drainage of lower limb? So, the blood vessels which are meant to drain the deoxygenated blood from the lower limb and return it to the heart is what constitute the venous drainage of lower limb. The venous drainage of lower limb is a lot more becomes a lot more complicated because it has to happen against gravity, unlike the rest of the body. Now, as we have learned just now, it is of great clinical and surgical significance. Moving on to the next heading, classification of veins of lower limb. Anatomical and functionally, the veins of the lower limb are put up in 3 groups. First one, superficial set of veins. Second one, deep set of veins. Third one, joining the superficial to the deep set are the perforating veins, or simply called as perforators. Now we are moving on to the next heading, that is description of each set of the vein. Before we dwell into it, let's have a quick look at the 3 sets of vein. The first picture is showing the superficial vein, the second picture is showing the deep vein, and the third picture shows up the perforating vein connecting the superficial to the deep veins. Starting with the first set of veins, superficial veins. As the name says, they lie in the superficial fascia just beneath the skin and over the deep fascia. They possess many valves along the course. And what is the purpose of these valves? Is they are meant for unidirectional flow of blood, that is towards the heart in the upward direction, preventing the backflow or the reflex of blood backwards. They drain into the deep vein through the perforating veins. The 2 major superficial veins of the lower limb are the great saphenous vein and the small saphenous vein. Now in this picture, I have put up the two superficial veins. The first one is showing, which I have highlighted in green, the great saphenous vein, and the second picture, which I have highlighted in purple, is showing the small saphenous vein. So the great saphenous and the small saphenous are the two superficial veins of the lower limb. Before moving on to the actual superficial vein, let us take a moment to learn about the dorsal venous arch. So it is a venous arch which lies in the superficial fascia of the dorsum of the foot over the head of metatarsal bones. It is formed by the union of dorsal distal veins and metatarsal veins. Its connections are what makes it important. So medially, it continues upwards as the great saphenous vein, and on the lateral aspect, it continues ascends as the small saphenous vein. The function of the dorsal venous arch is it collects venous blood from the entire foot and passes it on to the saphenous veins. Let us talk about the first superficial vein, which is great saphenous vein, otherwise called as a long saphenous vein. The name saphenous actually is a Greek word which literally means easily seen, meaning this great saphenous or small saphenous vein for the matter are easily seen, especially in thin individuals. And the special thing about this great saphenous or the long saphenous is it is the longest vein in the entire body, extending from upper part of the thigh until almost the foot region, and thus it becomes the longest vein of the body. Second point which I have put up there is the preaxial vein of the lower limb. Embryologically, during development, it is the preaxial. That means this vein lies cephalic to the axis of the lower limb bud. Now, as the lower limb bud is rotating medially, though it is in the upper part of the axis line, it comes to lie along the medial aspects of the lower limb bud. It has got 10 to 20 volts. Formation, it begins along the medial aspect of the foot region as a continuation of the medial end of the dorsal venous arch, supplemented by medial marginal vein. What is this medial marginal vein? It is the dorsal distal vein of the big toe. Now let us learn about the course of the great saphenous vein. After arising from the medial end of the dorsal venous arch, it ascends in front of the medial malleolus about 2.5 centimeters. Next, it ascends all across the medial aspect of the leg and reaches the posterior medial aspects of the knee joint, exactly a hand's breadth behind the medial end of patella. In the thigh region, it ascends all along the medial aspect until it reaches the saphenous opening. Now, what is the saphenous opening? Saphenous opening is an oval gap in the fascia lata in the upper part of the thigh region. Its exact location is 3 centimeters below and lateral to the pubic tubercle. One more point to be noted in the course of the great saphenous vein is it has copious amount of anastomosis with the small saphenous vein along with its branches. Now, let us see how it is ending, that is the termination. So, as soon as the great saphenous vein reaches the saphenous opening, it has to pierce a loose areolar tissue which is present over there, that is being called as cribriform fascia. After passing through the cribriform fascia, it passes through the anterior wall of the femoral sheath, entering into the femoral vein, therefore draining into it. Right at the junction of the great saphenous vein and the femoral vein, it is guarded or provided with a valve which is called as saphenofemoral valve. This saphenofemoral valve is of great functional significance because any incompetency in the saphenofemoral valve will invariably land up the great saphenous vein in varicosities. So until now, we have learned the formation, the course of the great saphenous and the termination of great saphenous vein. Now, let us move on to the tributaries of great saphenous vein. The first two which I have highlighted in pink in the picture and in the text are the tributaries which are present in the leg region. The posterior arch vein is a fairly big and a constant one, and it is present along the posterior aspect of the leg, meant for draining the posteromedial aspect of the leg, and it is connecting the three medial ankle perforators around the ankle joint. Anterior leg vein, as the name says, it meant for draining the anterior aspects of the leg, and finally ends up in great saphenous vein in just below the knee joint. Next, anterolateral vein and the posteromedial vein are the tributaries which are present along the thigh region. So, anterolateral, it starts from the anterior aspect of the lower part of the thigh and ascends up and ends up in the great saphenous vein. Posteromedial vein. So, it is meant for draining the posteromedial aspects of the thigh region. It is also called as accessory saphenous vein because it not only communicates with the great saphenous vein, it also channels up and communicates with small saphenous vein, and hence it is also called as accessory saphenous vein. Superficial epigastric vein, superficial circumflex iliac vein, and superficial external pudendal vein are three small tributaries which enter into the great saphenous vein just before it reaches out the saphenous opening. Superficial epigastric vein and superficial circumflex iliac vein are meant for draining the lower part of the anterior abdominal wall, that is below the level of umbilicus. Superficial external pudendal vein is meant for draining the part of scrotum or labium in case of females. The last tributary is deep external pudendal vein. So, it enters or drains into the great saphenous vein just as it is about to pierce into the femoral vein. And this deep external pudendal vein is meant for draining the anterior aspects of the perineum. Now we are moving on to our next superficial vein, that is small saphenous vein. As the name says, it is quite small when compared to the great saphenous vein, and it is also otherwise called as a short saphenous vein. Next, it is the post-axial vein of the lower limb, but it has 7 to 13 walls, and its formation, it begins from the lateral end of the dorsal venous arch, supplemented by the lateral marginal vein, which is the dorsal distal vein of the little toe. So now we have learned the formation of the small saphenous vein. Let us see the course of the small saphenous vein. After its formation, it passes behind the lateral malleolus, lateral to tendocalcaneus. So if you remember, the great saphenous vein is passing in front of the medial malleolus, and this is exactly opposite. The small saphenous is passing behind the lateral malleolus, right? And then it ascends lateral to the tendocalcaneus. After passing lateral to the tendocalcaneus, it ascends all along the back of the leg and then pierces the deep fascia. After that, it passes in between the two heads of the gastrocnemius and reaches the popliteal fossa. Termination. So as it has reached the popliteal fossa, it drains into the vein which is present in the popliteal fossa, which is the popliteal vein. Though most of the times it drains into the popliteal vein, the termination of the small saphenous vein can be quite variable. Sometimes it can bifurcate and a part of it can enter into the great saphenous. Sometimes it not even reaches the popliteal fossa and it can end up into the deep vein of the posterior compartment of the leg, that is the posterior tibial vein. The tributaries to the small saphenous vein are the deep veins of the foot. Most of them, yes, drain into the dorsal venous arch, but a few of them manage to drain into the small saphenous vein. Cutaneous veins of the posterior aspect of the leg. Until now, we have learned the formation, the course and the terminations of the superficial set of veins, that is our great saphenous and the small saphenous. Now I will end it with the nerves accompanying the saphenous veins. In the first picture, I am showing the nerves which are accompanying the great saphenous vein. As you can see there, the great saphenous is traveling right in front of the medial malleolus, where it is accompanied by a nerve which is the saphenous nerve. The saphenous nerve is a cutaneous branch belonging to femoral nerve. In the leg region and in around the ankle joint, that is in front of the medial malleolus, the great saphenous vein is accompanied by saphenous nerve. In the second picture, you can see the small saphenous nerve. The small saphenous nerve is accompanied by sural nerve, once again a communicating branch, cutaneous nerve, which is a branch belonging to both tibial nerve and common peroneal nerve. Now why are we learning about this is because of an important applied aspects in relation to this one. So it will come back to us. Just remember the nerve which is accompanying the great saphenous vein in the leg and in around the medial malleolus is saphenous nerve, and the nerve which is accompanying the small saphenous vein is the sural nerve. Now, as we have finished the superficial vein, we are moving on to the next set of veins, which is the deep veins. As the name says, they are deeply placed, supported and surrounded by muscles. They are enclosed in a sheet of thick, non-elastic deep fascia along with arteries. Numerous valves are present within the deep vein, and when compared to the superficial vein, the number of valves are a lot more. Now, let us learn the names of all the deep veins, right? So, the first one, anterior and posterior tibial vein, fibular vein, popliteal vein, and femoral vein. Anterior tibial, posterior tibial vein, fibular vein are the veins which are present in the leg region. Popliteal vein is present in the popliteal fossa, whereas the femoral vein is present in the femoral triangle and even the adductor canal. The point is, anterior tibial, posterior tibial, fibular vein, those who look like a single vein, they are actually venae committantes. What is a vena committante? It is a pair of veins which accompany the arteries and are fairly much interconnected. So, these anterior tibial, posterior tibial and fibular veins are actually vena committantes, which are accompanying anterior tibial artery, posterior tibial artery and fibular artery. Okay. Now, how are they formed? Anterior tibial is actually formed by the deep veins of the dorsum of the foot, whereas the posterior tibial vein and the fibular vein are formed by the vena committantes, which are accompanying the medial plantar and the lateral plantar arteries. Okay, so the anterior tibial, posterior tibial and the fibular vein are beginning from the veins of the foot region. So all of them combine together to drain up into the popliteal vein. The popliteal vein passes through the popliteal fossa, enters into the adductor canal via the adductor hiatus and then drains into the femoral vein. Femoral vein passes all along, ascends in the adductor canal, entering into the femoral triangle. It ascends all along the femoral triangle, is seen along with the femoral artery enclosed in a femoral sheath, and finally it drains up into the external iliac vein after passing beneath the inguinal ligament. So this is the story of the entire deep veins of the lower limb. Moving on to the next set and the last set of the venous drainage of the lower limb is the perforating veins. So as I have put up in the picture, they are actually communicating venous channels. So what are they communicating? They are communicating the superficial set of veins to the deep set of veins. They perforate the deep fascia, which is done obliquely. So if you look at all closely at the picture, They are not in a straight line. They are obliquely placed. So why it is significant? Because they are perforating the deep fascia, passing along the intermuscular septae in between muscles, right? So whenever the muscles are contracting, the obliquity of the deep veins make them collapsed, thereby preventing the backflow of blood into the superficial veins. Okay, so that is the reasoning behind they being oblique and how it is helpful in preventing the varicosity. Okay, now the major point, they have valves at either ends. This is because to regulate the unidirectional flow of blood from where to where, it is from superficial vein and to deep vein, not the other way around. So perforating vein are communicating venous channels which are meant for to regulate the unidirectional flow of blood from superficial vein to a deep vein. Location of perforators. The number and the location of perforator is fairly constant. Why should we learn about this location? Because of their major involvement in causing varicosities, it is better to have a working knowledge of the location of the perforators. Now let us learn about it. So first one which I have mentioned there is the mid-hunter perforator. Like the name says, it has something to do with Hunter's canal, which is the adductor canal. So the mid-hunter perforator, it communicates the great saphenous vein and the femoral vein present in the adductor canal. The knee perforator is otherwise called as Boyd's perforator, and it communicates the great saphenous vein to posterior tibial vein. It is present just a little bit below the knee joint. The three medial ankle perforators, meaning they are present on the medial aspects of the ankle joint. The topmost one is present at the junction of mid one-third and the lower one-third of the leg region. The lowermost of the medial ankle perforator is present just a little bit above the medial aspect of ankle joint, and the mid one is placed exactly in between these two upper and the lower medial ankle perforators. Okay, fine, we have learned the location. So now let's see what are they communicating. So the three medial ankle perforator, they communicate the great saphenous vein with the posterior tibial vein. Now the last perforator is the lateral ankle perforator. It is present on the lateral aspect of the ankle joint, just a little bit above the lateral malleolus. It communicates the small saphenous vein to the peroneal vein. Until now, we have learned everything about the superficial set of veins, the deep set of veins, and the perforators. Now we are going to learn what are all the factors helping in the venous return. As I have said earlier, the venous return in the lower limb becomes a little bit tricky because it has to happen against the force of gravity, and there are certain factors which are helping out, right? So the first point is contraction of calf muscles. As we learned earlier, the deep veins and the perforators are actually passing in between these muscles, right? So whenever we are walking or jogging, there is contraction of these calf muscles, thereby squeezing the movement of the blood within this vein in an upward direction towards the heart. So this is one major factor which is helping in the venous return from the lower limb, and these muscles are literally pumping the blood towards the heart, and hence it is being called as a musculovenous pump. One muscle which is helping out in a great deal doing this is soleus. Soleus is a flat muscle present in the posterior compartment of the thigh, as it is helping out in pumping the blood towards the heart. It is aptly called as the peripheral heart or tricipital pump or skeletal pump. That is the first point. Second one, the transmitted pulsations of adjacent arteries. The deep veins are always traveling along with their arterial counterparts enclosed tightly in a sheet, and hence The pulsations of these arteries, which are along with the vein, have, are helping the movement of the blood within the vein in an upward direction. Third, and very important point helping out in the venous return of lower limb is the presence of valves. The picture I have put up over there, please have a look at it. We can see the valves which are helping in the unidirectional flow of blood. Now before that, what are valves? Valves are bilaminar folds of endothelium. Whenever they are coming together, they are occluding the lumen of the vein, thereby preventing the backflow or the reflux of the blood and thereby helping in the upward movement of the blood. That is one point. And the other point is presence of this valve divides the entire column of blood into smaller segments, thereby decreasing the pressure within the long saphenous or the saphenous vein, which are quite lengthier, right? Takes 3 points. Contraction of calf muscles, transmitted pulsations of the arteries, and the presence of valves are actually quite helpful only whenever we are in an upright position. But what happens in a recumbent position? That is when we are lying down. That is what we call as a bis a turbo. That is contraction of the heart and the suction action of the diaphragm, especially during inspiration, are enough during recumbent position to draw the venous blood from the lower limb towards the heart. As I have told in my earlier slide, it is actually the soleus, a muscle in the posterior compartment of the leg, which is helping out in a great detail in pumping the blood within the veins in an upward direction towards the heart. Just like our heart, which is pumping blood to the entire body, the soleus is also doing the same thing, and hence it is being aptly called as the peripheral heart or sural or tricipital pump or skeletal muscle pump. One more thing I would like to talk about regarding soleus is have a look at the picture, the first diagram. In this picture, you can see the veins which are draining, passing through the soleus muscle is not actually a single vein, unlike in all the muscles. It's actually in the form of a sinuses, that are spaces which are occupied by venous blood without any walls. So why is this relevant? Because whenever the soleus muscle is pumping, it will be directing all this blood into the deeper chain. Whenever it is relaxing, it draws the blood from the superficial vein. This is how it works while it is in action, that is whenever we are moving. But whenever we are resting, that is lying upon the bed for a prolonged amount of time, it becomes passive. That is the movement of blood within the soleus sinuses becomes sluggish, and it leads to the pooling of blood within the sinuses, leading to a clot formation, which could be a little bit tricky. So we'll be learning about this while we are talking about the clinical aspect. So for now, remember that within the soleus, the venous blood, the veins are not in the form of a single vein. It is in the form of sinuses without any valves. Now we have moved on to the most interesting topic, that how are we going to apply whatever we have learned until now clinically in our day-to-day practice. Check it out. The first and the foremost are the varicose veins. So what is this varicose vein? To define, it is pathological undue dilatation and tortuosity of superficial veins of lower limbs. So it is not only the lower limbs, it could be affected any vein in the entire body, but most commonly affected regions are the lower limbs and the pelvic area. Usually it presents to us as dark purple or blue colored cords of swollen and twisted veins. That is the usual presentation the patient will be coming to us. The prevalence. The prevalence of varicose veins in USA, it is 23%. And if we add up the spider veins or reticular veins, which are the milder form of varicose vein, the prevalence will be increasing much more. Now let us see what are all the risk factors. Who is getting these varicose veins and why? First is family history. So if you have a parent suffering from varicose vein is most likely you will also be suffering from it. Not for sure, but you are most likely. Next, obesity. Being overweight puts a lot of pressure on the superficial vein, leading to its laxity, which in turn leads to varicosity. Increased age. So as we age up, the veins lose their elasticity. They become stiff and more prone to varicosity. And even the valves, because of wear and tear, they lose their working module and thereby the backflow of blood increases leading up to varicosities. Next, females. When compared to males, females are at a greater risk of suffering from varicosities. The reasoning behind this is the hormones. The hormones during pregnancy, the hormones which go heavier in women who are taking birth control pills and during menopause puts them at a greater risk. So because of the female hormone leading to laxity of the walls of the veins. Lastly, occupations which require prolonged standing, especially in people who are bus conductors, nurses, where the prolonged standing is the norm, it puts up greater pressure on the veins and the valves, leading to once again varicosities. So these are all the risk factors for the happening of the varicose veins. Now, we have learned what is varicose veins, what are the risk factors of varicose veins, right? Now, let us learn a little bit about the pathology, how it is happening, right? So, first and the foremost cause for the occurrence of varicose veins is incompetency of the valves. In the picture I have put up in the upper part, have a look at it. The first one is a healthy vein where the valves are very much competent and thereby directing the flow of blood in unidirectional, that is in the upward direction. Whereas the same in the diseased vein, the walls are not closing properly, thereby allowing the reflex of the blood, that is bidirectional flow of blood. Whenever that happens, that puts up the pressure on the low pressured low pressure the superficial vein, leading to pulling up of the venous blood, which makes them dilated and tortuous, which is our varicosities. The second point is persistent elevation of intra-abdominal pressure. So, how is it leading to varicose veins? Let us see. Persistent elevation of intra-abdominal pressure, it is usually seen in any intra-abdominal tumor, multiple pregnancies, chronic cough or chronic constipation. In all these scenarios, the problem is it puts up a lots of pressure on the inferior vena cava. Inferior vena cava is the ultimate vein onto which the entire venous blood of the lower limb will be reaching. So whenever pressure is being put up on the inferior vena cava, the venous blood will be flowing back, leading to the pressure within the saphenous vein, which in turn leads to varicosities. The last reason is the thrombosis of deep vein, which could put pressure onto the superficial vein, that is the saphenous veins, leading to varicosities. Now that we have learned everything about the varicose vein, we know who is the culprit. The most common culprit is definitely the incompetent valves. Valves are present in superficial veins, in deep veins and in the perforators, right? How to know which one is the faulty one? So, there are a few tests which we could do at bedside to assess which one is competent, which one is incompetent, right? There are many tests, but there are two tests which are quite important, which are easy to do. Which first one is Brody Trendelenburg's test. The second one is Perth's test. In the Trendelenburg's test, usually is done to check the competency of valves within the superficial, the major one, saphenofemoral valve, and the valves within the perforators. Let us move on to the procedure to see how it is done. So, to do this, the patient is asked to lie down. The whole lower limb is exposed, and then the patient is asked to lift or elevate the lower limb. This is done so as to empty the entire varicose veins, and then we tie a tourniquet just below the saphenofemoral junction. Then the patient is quickly asked to stand up. In the first scenario, the tourniquet is not removed. Now, the lower limb is observed. If at all, the filling up of saphenous vein is observed from below upwards within 30 to 60 seconds. It indicates perforator vein incompetence. Next, look at the second picture. In the second scenario, the tourniquet is removed and then the limb is observed. If the saphenous vein fills up as soon as we remove the tourniquet, it definitely indicates the incompetence of saphenofemoral valve. The second test is the pulse test. It is done to check the competency of the deep veins. Trendelenburg's test is to check the competency of the superficial vein and the perforator, whereas this one is to check the competency of deep veins. In this test, we tie a tourniquet in the upper part of the thigh and we ask the patient to walk around for a while as we observe the limbs. If the deep veins and perforators are normal, the varicosities will shrink, as in the picture in the point B. Now look at the last limb in the picture. If at all the deep veins and perforators are insufficient, if the valves within them are not working properly, the varicosities will become more distended. That's how we come to know if at all the deep veins, the valves within them are competent or not. As we have learned everything about the varicose vein, let us move on to the second clinical scenario, deep vein thrombosis. As in the picture, the deep vein thrombosis actually presents as an erythematous, inflamed and with quite extremely painful leg. It could happen in any part of the body, but most commonly once again seen in lower limb. It is usually seen in patients who are bedridden for a while, that is during in their hospital stay after a medical or a surgical condition. The question we need to think over, why is it happening in bedridden people, right? Because during as we are bedridden for a while, the venous blood within these muscles, especially the soleus, gets pulled up. So until unless we keep moving, the muscles are not contracting. If the muscles are not contracting, the blood within these muscles, especially the soleus, gets pulled up. Whenever there is pulling of blood, added to it some issues with coagulation, it leads to a clot formation, that is a thrombus. Okay. Now, this is a thrombus. If at all it gets dislodged as is shown in the picture, if it is getting dislodged, we call it an embolus. So, an embolus within the deep vein can pass up all along the deep veins, reach up the heart from the right atrium. It can end up in right ventricle and through the pulmonary arterial trunk, it could end up in lung, leading to pulmonary embolism. Pulmonary embolism is a serious emergency which could land up the patient in death. So, one of the dreadful complications of deep vein thrombosis is pulmonary embolism. So, unless it is treated on an emergency basis, we could lose the patient, and hence this has to be taken care. The best prevention for deep vein thrombosis is early mobilization of the patient as soon as it is possible. The next clinical aspect is using the great saphenous vein as a venous graft in CABG. CABG stands for coronary artery bypass graft. So, the usual story which we are listening these days are he or she suffered from a heart attack, they went for an angio and then they underwent a surgery, that is a bypass surgery, right? This is the usual story which we have been listening very recently all over. Now, what is this bypass and what is being bypassed? Let us have a look at the first picture before. So there we can see the right coronary artery which is blocked, leading to an infarct formation. Even the left anterior descending artery is also blocked, leading to infarction of an anterior wall of the left ventricle, right? Now look at the after picture. There is a venous graft which is done, which is used to bypass the obstructed part of the right coronary artery, and it is connecting the aorta to the coronary artery. Okay, so it is aortocoronary bypass. The thing which is bypassed is the obstructed or narrowed part of the coronary artery. And the great saphenous vein is the most commonly used vein when it comes to a venous graft. It could be an arterial graft also, but because of the accessibility of the great saphenous vein, it is the most commonly used graft in CABG, that is coronary artery bypass grafting procedure, commonly done in coronary artery disease. The next clinical aspect is venesection of great saphenous vein. So, venesection is cutting up a part of the vein to gain access, that is to put up a cannula to administer IV fluids, that is intravenous fluids. We might have observed that the venesection or administration of the intravenous fluids is usually done in the veins of upper limb, right? But in case of emergency conditions like in burns and all, where the veins of the entire body are collapsed and cannot be accessed, it comes to the great saphenous vein for the venesection to gain to administer the intravenous fluids. The point at which it can be easily accessed is when it passes right in front of the medial malleolus. So in this picture, we can see that the great saphenous vein is being ligated right in front of the medial malleolus. The thing is, we know that there is a nerve which is passing along with it at that point. That is our saphenous nerve. So whenever we are putting a ligature during the venesection procedure, we should be careful not to include the saphenous nerve which is passing along with it. Now we have finished the entire topic. Let us do a quick summary of all the things which we have learned until now. So, the venous drainage of the lower limb is drained by three sets of veins. One, superficial. Second, deep set of veins. The third, the perforators. The superficial set of veins are great saphenous vein, small saphenous vein. Both of them start from the dorsal venous arch. The small saphenous vein drains into popliteal vein. The great saphenous vein drains into the femoral vein. Femoral and popliteal are deep veins. These superficial veins, that is great and the short saphenous vein, are interconnected to the deep veins via communicating channels which are called as perforators. Next, moving on to the deep veins, the deep set of veins in case of foot and leg are in the form of vena combatantes. So, in the leg, we have got anterior tibial vein, posterior tibial vein and fibular vein. So, all of the three of them unite to drain into popliteal vein. The popliteal vein passes upwards so as to drain into the femoral vein. Femoral vein then passes beneath the inguinal ligament so as to drain into external iliac vein. So, the point is the entire venous blood from the superficial, it passes through the perforators into the deep veins. Now, the entire venous blood of the entire lower limb is being drained finally into the femoral vein, which in turn ends up in external iliac vein. So this one is a schematic diagram showing the same thing which I have told before. One more point I would like to add up is superficial veins, deep veins and the perforators. All of them contain walls which are actually meant for unidirectional flow of blood towards the heart. Now, we know that the venous drainage of the entire lower limb has reached the external iliac vein via the femoral vein, right? But the final destination is not the external iliac vein. The final destination of the entire venous drainage from the entire body is the right atrium of the heart. Now, how is this external iliac vein reaching the right atrium? The external iliac vein joins up with the internal iliac vein to become the common iliac vein. The right and the left common iliac veins unite to form inferior vena cava. The inferior vena cava passes all along the abdomen, enters into the thorax passing via the diaphragm and finally opens up into the posterior aspect of the right atrium. Thereby, our entire venous blood from the lower limb has reached its final destination, that is the right atrium. So, that is the summary of the entire venous drainage of lower limb. Now we have learned everything about the venous drainage of lower limb. Let us quickly assess how much you have understood. Okay. So let us do 5 multiple choice questions. First one, peripheral heart is option A, gastrocnemius, option B, soleus, option B, tibialis posterior, option D, tibialis anterior. So what do you think? Yes, it is soleus, which is called as the peripheral heart because of its major involvement in pumping the venous blood of the leg region in an upward direction towards the heart, and hence it is called as the peripheral heart. Second question, the great saphenous vein drains into option A, femoral vein, option B, peroneal vein, option C, popliteal vein, option D, posterior tibial vein. Yes, the answer is femoral vein. Third question, one of the following is a deep vein of lower limb. Option A, small saphenous vein. Option B, dorsal venous arch. Option C, the great saphenous vein. Option D, femoral vein. The first three are superficial set of vein. The small saphenous, dorsal venous arch, the great saphenous are the superficial set of veins present in the superficial fascia, whereas the femoral vein belongs to the deep set of veins. So answer is D, femoral vein. Question number 4. A patient with varicose veins is experiencing problems with option A, lymphatic drainage of lower limb. Option B, arteries which are supplying the lower limb. Option C, venous drainage of lower limb. Option D, all of the above. We know this, right? Yes, a patient with varicose veins is definitely experiencing problems with venous drainage of lower limb, which is option C. One of the following vein is used in coronary artery bypass grafting procedure. That is our CAPG procedure. Options are femoral vein, B, popliteal vein, C, great saphenous vein. Option D is the small saphenous vein. The answer is option C, great saphenous vein is the one which is most commonly used because of its easy accessibility, and even if it is ligated and removed because the copious amount of collateral circulation, there won't be any issue with the venous return coming from lower limb, and hence it is usually preferred over any other veins. So we have come to a conclusion. That is the end of my topic. If at all, if you have any question, you can reach out to me. And above all, thank you so much for patient listening. Have a good day.